So really, we use TPN when we want to optimize nutrition and we know that the baby isn't going to be on full feeds for several days. Hello and welcome to Tala Talks NICU. Today we are talking about TPN, and this video is part 1 in a 2-video series on TPN. In this first part, we will go over 1. General information about TPN, 2. When do we use TPN, 3. How is TPN administered, 4. How is TPN ordered, and 5. The main differences between central TPN and peripheral TPN. In the next video, we'll go over how to actually write for the TPN. So that will have a lot more practical advice. We'll go over how to write for the rate and then all the different components that go into making up TPN. So stay tuned for that one. Before I start, this is just a really quick reminder to ask you to subscribe to the channel and to like this video and to let us know what you'd like us to film next. And also to go do all the multiple choice questions under the community channel. They will really help all this information stick. So number 1, some general information about TPN. As you all know, TPN stands for Total Parenteral Nutrition. Total because it tries to provide all the metabolic requirements that a baby needs for both nutrition and growth. And parenteral because this form of nutrition bypasses the gut, so it's parenteral and goes directly into the bloodstream. TPN basically has a sterile water base, and then it has, like we keep saying, all the nutrition that a baby would need. So it has all the macronutrients, and there are 3 macronutrients: carbohydrates, normally given in the form of dextrose or glucose, and then proteins, normally given in the form of amino acids, and then fatty acids, normally given in some form of lipid emulsion. Then on top of that, it also has all the other vitamins and minerals and anything else that the baby might need. The concept and application of TPN in the NICU really changed the course and the outcomes for these premature babies. It has been known for an extremely long time that premature babies aren't capable of tolerating all the feeds they need for nutrition and growth, and so they definitely do need some sort of external energy source. So in the 1960s, before these babies could actually tolerate their feeds, this external energy source was given in the form of just a pure glucose solution. So just IV dextrose was given. Then, after a few successful studies in the 1960s, an amino acid solution was added to the dextrose, so kind of equivalent to our starter or vanilla TPN now. And as we'll talk about in the next video, having this early administration of the protein really helped the overall growth for these premature babies. This was followed in the 1970s and early 1980s with the addition of a lipid emulsion or a fatty acid administration to the babies with TPN. What was fantastic about this, apart from the fact that we no longer had to worry about essential fatty acid deficiencies in these babies, is that because fats have a much higher caloric concentration compared to proteins and glucoses, we were finally able to give these babies a good caloric load, which is what they needed for their growth. TPN has evolved a lot even since the 1980s, with a lot of different micronutrients being added, hoping to make it as close to total nutrition as we can, or really, like we said in the last video, as close as possible to what the mothers would be giving the babies if the baby was still in utero, obviously if the baby were premature. Most recently, different types of fat emulsions have been developed which are less damaging to the liver. As you probably all know, damage to the liver or hepatotoxicity is what we really worry about when babies are on TPN for a long period of time. We highly encourage you to go watch the video on short bowel syndrome that we made, and in it, it really talks about the different techniques of administration of TPN that we can use to try to reduce that damage to the liver or reduce hepatotoxicity as much as possible. So, as you're probably gathering, the science of the TPN is constantly evolving and improving, hopefully as we get closer and closer to that ideal nutrition that we can give babies, whilst also making it as minimally toxic as possible. Number 2, when do we use TPN? Different national and international organizations give pretty concrete recommendations for exactly when TPN should be used. But in reality, in most units, it's a call between the providers as well as the nutritionists, hopefully if you have nutritionists in your unit. As you all know, we all pretty routinely use TPN for premature infants, especially those less than about 31 to 32 weeks gestational age and those less than about 1,200 grams. And it is really preferable that that TPN, or at least some form of TPN with glucose and amino acids, is started as soon as possible after birth to get that positive growth going almost immediately. We also use TPN when an infant can't be fed for several days. So this could be because they were born with a GI issue like a bad atresia or a gastroschisis, or it could be because they're just really sick at birth and you don't really want to kind of add any extra stress to the gut. So for example, a baby with a bad sepsis or a bad HIE. So really, we use TPN when we want to optimize nutrition and we know that the baby isn't going to be on full feeds for several days. It's a pretty gray area, but the good thing about TPN is that even if you don't immediately start a baby on TPN, for example, you've got a 1,600 gram baby who looks like they're kind of doing okay and might not need the full TPN. And so you just start them on a starter TPN or even just dextrose. If, for example, on day 3, that baby is not even tolerating trophic feeds at that point, then maybe at that point you could consider starting TPN to make sure that the infant's getting its caloric needs. Number 3, how is TPN administered? So we already said that TPN is given into the blood, and generally we run the total bag of the nutrition over a period of 24 hours. So however much nutrition that we want to give the baby in a day, it's divided by 24 hours, and then that's the rate that we run it each hour. In most instances, the lipids or the fat emulsion is in a separate bag from the TPN. And most of the time we run the lipids over 24 hours as well. There's one exception to that, and that's Omegavan that we generally run over 12 hours. But apart from that, we run the TPN and the intralipids throughout the course of the day. Even though they are in 2 separate bags, they can both go into the same vein. Changing the TPN and setting up the lines and everything is very much a nursing procedure, so a very important one. So if you do have interest in that, then please comment below and I will try to convince Ariana to do a whole video on exactly how to change TPN lines. Different committees have gone backwards and forwards about whether we need to protect the bags of the TPN as well as the lipids from light. The concern is that light, even in the visible spectrum, could cause damage to the bags of TPN and intralipids. Specifically, it could degrade some of the nutrients and cause some level of photooxidation, which produces free radicals. Free radicals can be really bad for the baby, and you're worried about an increased risk of BPD and ROP, for example. Based on these concerns, ASPEN, which is the American Society for Parenteral and Enteral Nutrition, recently recommended in 2021 that we should be covering these bags with plastic so that the contents are protected from light. Number 4, how is the TPN ordered? Normally, the provider or the nutritionist writes for the TPN, and in a lot of places, it is all computerized. It's fantastic when it's computerized because then the computer can automatically tell you that you have too many ingredients for the volume that was given, or that you forgot to put in heparin even though you're putting it into a central line, or that the solution is not soluble. So ideally, the TPN is written directly into a computer program. Writing TPN actually involves a lot of trial and error. There are some general rules that we follow, the general rough volume that a baby needs over the course of the day, depending on its gestational age and actual age, postmenstrual age, as well as how quickly we advance the amino acids and the lipids. But there's a lot of other things that we do that are just a lot of trial and error. And the reason for this is that there are so many different factors that go into determining the metabolic and nutritional requirements of any baby. So So it's not just the gestational age of the baby and the weight and how many days old the baby is, but it also depends on the medical condition of the baby. So for example, if a baby is breathing 100 times a minute, they are obviously going to need more calories than a baby breathing 50 times a minute. Different babies could also be on different medications. So for example, if a baby is on diuretics, they're going to need more sodium and potassium supplementation, for example. Babies could have different renal and liver functions, and that also will affect the type of TPN that we'd be writing. And very often, babies just do completely unexpected things that we can't even predict when we first started writing the TPN, which is why there is a lot of trial and error. This is why it's important to follow the baby closely while we're on TPN. So for example, when a baby is first placed on TPN or when the new bag of TPN is changed out, we always have to check the baby's sugars to make sure that the baby is tolerating that same sugar or an increased sugar in the TPN. Also, while a baby is on TPN, until they've reached some sort of status quo, so that we're giving pretty much the same TPN every single day, it's really important to follow the baby's weights, the baby's urine output, as well as electrolytes to see what sort of changes we need to make in the TPN for the following day. Another complication with writing for TPN is that we normally write for it in the morning, so as soon as the morning labs have come back. And because it's actually a really complicated thing to make, normally we can't actually hang the TPN until at least the afternoon. Sometimes the evening, sometimes the night shift is hanging the TPN. So often the baby's status will have changed from the time that we've written the TPN to when the TPN is being hung. And sometimes we can't actually even hang that TPN that was originally written for. One last thing I'll say about making a bag of TPN is that it's a really complicated process. So even if the doctor has written or the provider has written an appropriate TPN and it's been checked appropriately by the computer system, the actual process of making the bag of TPN and making sure that it's sterile is not an easy process. Not just the pharmacists don't just have to worry about the actual ingredients going in, but they have to make sure that there aren't any solubility issues and that all the ingredients fit in the amount of sterile water that was written for. So because of this, mistakes can be made, and we just have to be aware of that. So if you do somehow get really abnormal labs, so for example, the sugars just suddenly goes through the roof or suddenly plummets after starting a new bag of TPN, or the following morning you have a really abnormally high calcium or abnormally high potassium, then you have to assume in the back of your mind that this could be the TPN. And the first step to do would be to actually stop the bag until you can prove it. Just like everything in medicine, nothing is foolproof. So always assume that there is some little error that could be happening. Number 5, now let's talk briefly about differences between central TPN and peripheral TPN. When we talk about central TPN, we are talking about the TPN that would be administered through a central catheter. And a central catheter is a catheter that ends up in a vein that's central or that's closer to the heart, so a much bigger vein. So basically we're talking about a PICC line, so go watch that video on PICC lines, or a Broviac, so a surgically placed central catheter, or a umbilical venous catheter, or some institutions even put TPN through a UAC, or an umbilical arterial catheter. I'll just say this as a quick aside about running TPN through a UAC. There isn't a lot of great data on it about whether it is superior or inferior or just the same as running TPN through a UVC. Just like a lot of things in neonatology, it's very difficult to prove. Generally, most institutions, even if they do end up doing that, will try to run the TPN through into venous access, but if they're really desperate, then they'll end up using the arterial access because that's better than not having any access at all. Peripheral TPN is the TPN that's run directly into a peripheral intravenous catheter, so into a PIV. So it could be in the arms or the legs or even the scalp. As you know, the big difference between the veins is actually the size of the veins. And what we're worried about is that in the smaller veins, the catheter is more likely to either slip out or to damage, or the fluids are more likely to damage that vein. And so again, the vein itself is kind of blown. This will end up with an extravasation, so the fluids are seeping into the surrounding tissue, as well as an infiltration of that surrounding tissue. When this happens, the damage might be minor. For example, if just a little bit of dextrose and amino acids was running through a PIV and it got caught early, then there would just be a little bit of swelling there. But it can also lead to some serious damages. It can end up causing pretty bad skin necrosis, as well as kind of functional impairment of that limb. Because of this concern that a higher concentration of the TPN will damage the vein and cause it to blow or the fluids to infiltrate and everything, we try to use a lower osmolarity or a lower concentration of the TPN when we're putting the TPN through a PIV. The hope is that a lower osmolarity of the TPN is less likely to cause thrombophlebitis. Like I said, osmolarity is basically the concentration of the fluid. The two components of TPN that contribute the most towards osmolarity are the dextrose as well as the amino acids. The electrolytes play a lesser role, but they do also contribute a little bit to the osmolarity. The osmolarity will be calculated on every single TPN bag that is given. So always get used to looking for it, looking at the sticker on the TPN bag that's made. It's also calculated immediately on any program or any computer program that you're writing the TPN on. So get used to always looking at that number. Based on these concerns, ASPEN, or the American Society for Parenteral and Enteral Nutrition, recommends that if we are going to run TPN through a PIV, we should not let that TPN have an osmolarity above 900 milliosmoles per liter. Many neonatal intensive care units use even a slightly higher osmolarity. For example, maybe push it up to about 1,000 milliosmoles per liter. But the truth is it's all quite an arbitrary cutoff, and it's been really very difficult to prove that even an osmolarity of 1,250 milliosmoles per liter is significantly worse than 1,000. And you can imagine why some providers are really trying to maximize the milliosmoles as much as possible through the PIV, because dextrose and protein are huge nutritional blocks for what the baby needs. And maxing out the milliosmoles at 1,000 really limits the amount of dextrose and protein that we'd be able to give a baby. But like a lot of things in medicine, if an expert organization recommends something and you do something differently and it goes wrong, then it is kind of on you. So we do at least have to be very aware of what all these expert organizations are recommending. The other big accepted recommendation for giving TPN peripherally is that the maximum glucose concentration that should be used is a dextrose of 12.5 grams per 100 mLs, or a dextrose of 12.5 W. Again, there isn't fantastic evidence for this, but it is thought that the higher the glucose concentration that we use, the higher the chance that that vein is going to get very irritated. Giving calcium via a peripheral IV is not a contraindication. So for example, if you have an infant who's literally having a seizure because they're so hypocalcemic and the only access that you have is a peripheral IV, then absolutely you're going to give calcium gluconate or whatever via the peripheral IV. The concern is if the calcium is being given through the PIV and that vein blows or slips out or something and the calcium goes into the surrounding tissue, it can be really, really damaging. So almost immediately there can be just a lot of swelling and irritation, and then that can kind of end up with calcification literally right underneath the skin. And this can end up with scarring and some really huge functional abnormalities of wherever that IV was. So even though it's not an absolute contraindication, many units choose not to give calcium through the PIV just because of that increased risk of getting a really bad calcium infiltrate like that. And the last thing I'll say about peripheral TPNs is that if you are running the TPN through a PIV, you don't need heparin. You're not worried about that tiny little catheter from clotting off. And if there is heparin in the bag, that's not a contraindication to giving it peripherally. So even though we don't like to give medicines if we don't need it, If the TPN is made with heparin in it and you really do want to use it, you can use that TPN through the PIV. So in summary, say that a bag of TPN was written in the morning for a PICC line, and the PICC line at some point of the day became clotted or was leaking and we decided to take it out. Then you have a decision to make. Can you run that TPN through a peripheral IV? So there's three main things that you have to look at on the bag. The first one is the milliosmoles greater than 900 to 1,000 milliosmoles per liter? 2, is the dextrose concentration higher than 12.5? And 3, is there calcium in it? If the answer to any of these questions is yes, then you probably should just go ahead and make another fluid and not run that TPN through the peripheral IV. Okay, that was our quick introduction to TPN. I hope that you learned something. Please remember again to like and to subscribe, and stay tuned for the next video where we go in more details about how actually to write the TPN itself. Thank you for being here.